Hello, everybody. It's time for a new GYN Garage. My name's Ed Pavlik, and I'm in Lexington, Kentucky, in the second day of the government shutdown in the U.S., where the weather is in the 70s and very comfortable. Soon, I think the frost is going to be on our pumpkin. My colleague today is
Frank Lawton from London, United Kingdom. And autumn is, or fall is coming in. The tree, it's still very, very sunny and quite warm, but the trees are now beginning to get the autumn colours, and it's really quite stunning at the moment. It's beautiful, beautiful. But it is getting colder in the evenings. We'll be getting frost soon, I think, and misty fruitfulness is how somebody described autumn. Season of misty fruitfulness. It's certainly going to come that way. Looking forward to it. I like all the seasons. I always feel that countries that don't really have seasons are missing out on something. My favorite season is always the one I'm in the middle of. I love autumn, but I look forward to winter, and then I think, oh, spring's going to be here soon, and then it's summer. But it's good. That's the way it should be.
absolutely. Well, let me say that I know that we've talked about the Arctic before, and and your trip to the Arctic. And since then, I've run into somebody who asked me if you had visited any of the pitches in the Arctic in Norway. And I didn't know what he was talking about, but he had said that the nicest, most beautiful pitches he's ever seen were in the Lofoten Islands uh,
Yes.
and a couple other places up that far. Did you notice any of those?
Um, we were in the Lofoten Islands. I didn't particularly notice them. No, perhaps I was looking in the wrong direction. It was it was they are most beautiful. They're stunning, and the mountains and the fjords and the waterfalls. No, but I didn't particularly notice anything like that.
Well,
Perhaps we were in the wrong bit.
I'll send you a link because I had to look it up after he told me that. And so
Okay.
you can see what you missed.
Go back again. Yeah.
Right, go back again. Well, today we're going to consider the question, does surgical volume guarantee optimal surgical staging or complete macroscopic resection? These are sort of surrogates for the quality of what's going on. Um, Answer to this question is approached in a paper titled Increasing Correlation of Surgical Volume in Gynecologic Cancer Centers with the Quality of Ovarian Cancer Care. This paper was recently published in the Journal of Cancer Research and Clinical Oncology. This work investigates if institutions with higher volumes of surgeries on women with ovarian cancer have better rates of surgical staging or complete macroscopic resection. Frank, give us your insights.
Okay, I think this is quite a difficult paper, and it's not particularly easy to read. It goes on for 11 pages. There's a lot of data, but in the end, it's just an audit of the certified cancer centers in Germany and also Austria and Switzerland. And in a way, all, well, let me start at the beginning. There are 193 cancer centers in those three countries. The population density of those three countries is 500 and odd people per square kilometer. If you add together the population density of California, Florida, and New York State, it's actually the population density is a bit less than that, but there are only 22 cancer centers in those three states. So it's almost inevitable that within this population, they are going to find cancer centers which are certified, but which have very, very small numbers. 193 cancer centers is a heck of a number for the population we're talking about. So the first thing I wondered, where is the pressure coming from to audit these data further? The way the cancer centers are certified is that every year or every 3 years or whatever it is, the centers have to put in the data of how many cases they've done, with the histology, etc. So these data are already known. Now, has someone come along and said, but some centers are only dealing with a very small number and therefore have not got the skill or the resources to handle the caseload. But obviously they're certified. They have the number of gynecological oncologists there. They have the tumor board every week, etc., etc. So I'm not quite sure what the idea of this audit is about. Are they trying to close down smaller cancer centres, or are they just saying, well, the smaller cancer centres are just as good as the larger ones from outcomes? They need at least 50 cases a year. It's not defined as to what those 50 cases should be. So in actual fact, they could all be cases of endometrial cancer and very few cases of ovarian cancer, because the histology is not defined. But what they've tried to do is looked at two, as you say, surrogates for quality of surgery, staging for stage 1 to 3A disease, and complete macroscopic tumor clearance for 2B to 4. And they've been the quality, so they're the surrogates, and they've looked at centres which have between 10 and 25 cases of ovarian cancer per year. The numbers are pretty good. The staging numbers are nearly 4,000, and the debulking ones and 7,000 and odd. So I think they've certainly got enough numbers, but they've spread over, as I said, 193 cancer centres, and we don't know how many of ovarian cancers they're dealing with. The results surprised me a little bit that 75% of these cancer centres see less than 10 patients with ovarian cancer a year. 10 patients, 2 gynecological oncologists at least, 5 a year. That means they're doing, with holidays and leave, etc. These gynae oncologists are only doing a case every 2 months or so. Now, they may be perfectly satisfactory surgeons, but surely the whole point of this paper is that small numbers equals suboptimal care. And only 1% of cases see, 1% of the centres see over 25 cases. So again, it's terribly diluted, these data, and they've had to put them all together to get some idea of the results. From a treatment point of view, from the treatment point of view, 45% of the hospitals see less than 10%, less than 10 patients a year. And from a staging point of view, there is an improvement in staging quality, that it's at 18% better staging rate amongst the case in hospitals where they do more than 15 cases a year, and compared with less than 15. So the high volume cancer centres do, as we would expect, have an improvement, but it's only 2 to 3%. The paper actually says that the complete resection rate amongst the higher centres, the high volume centres, is not that much better than those amongst the smaller centres. So that's the problem I have with just the way the study's been worked out. Another problem is it doesn't say at all in the paper whether they're dealing with epithelial ovarian cancers or germ cell tumours and stromal cancers, which have a different surgical expertise needed. There's certainly, you may not need as much surgical expertise in the upper abdomen if you're dealing with non-epithelial cancers. We also, of course, don't know the number of patients who had interventional surgery following neoadjuvant chemotherapy, and I think that's important from the point of view of surgical outcome. There is no doubt that neoadjuvant chemotherapy makes surgical excision easier. I don't think there's any doubt about that. There are also no survival data, and I don't really understand why, because if these cases are looked at every 2 years in order to gain accreditation, this recertification, why have they not been able to provide them with survival data? Because that's going to be important, obviously. In the paper, the authors say correlation with survival is not possible because of centre aggregated data, and I haven't got a clue what that means. I think it means they just didn't bother to try and find out whether the centres that had a big caseload did better or worse. The cases with the centres with the bigger caseloads may actually be doing more extensive surgery, and there are no complication rates. We haven't got a clue whether the patients that have the more complicated surgery do have greater complications. So I think in the end, this is just, it's an audit. I think the reason for it being carried out is been unknown to me. I don't think the data are actually pretty good, and I don't think it actually. I I don't think if anybody was trying to set up a gynecological cancer center and use these data, I don't think it would have a leg to stand on. I think that to say they are, but look, the results are the same. That's not the way gynecological cancer centers or centers of expertise work. And so I think this paper, if it has any influence at all, will have a very negative impact on care of gynecological cancer patients. Some surgeons might say, but look, my results was we only do 10 patients a year, but my results were as good as the case down the road that has 35 cases a year. And I don't think that is feasible.
Well, I think that's right. I think what I'm left with commenting on is if we make some guesses about what's going on. I think one thing is that there's the surgeon's mind, and that's he knows he's going to be punished if he's doing incomplete surgery. So he may be willing to face up to OR time that's going to be greater for doing more extensive surgery and just do it. And he's backed up by the literature. We know that there is a survival advantage for leaving behind very little disease to those people. So I mean, I think that's a very human type of factor. Now, staging is something different. And my guess, the stab I'll take on this is with regard to paying for all these things. Now, this relates to how it is here in the States, but I'll say that the German system is somewhat of a hybrid. 90% of the people are state-supported healthcare, 10% are private insurance. The idea is there might be a similarity in my mind to the States, and that would be your reimbursement in the States to support students, residents, and fellows causes your expenses to go up on a per bed basis. And so if there's a pressure in non-teaching centers to keep those expenses down, one of the places they could be kept down is at staging. And that may well be happening, that there is a financial pressure coming in between the private insurers in Germany and whatever is coming through on public financing. And so I'll put out there that I'm guessing that the bed fees, the cost per bed, are being kept down in non-teaching centers, where the biggest difference was in the paper. That's the difference between complete surgical staging and those places that where there has to be support for teaching students, residents, and fellows.
Yeah.
So, that's my guess of what's going on. Now, I will say on your first comment, I was so shocked that we were having the same thing, but I could not figure out why I was so uncomfortable reading this paper, but it was a burdensome, not easy to read, not well written was the bottom line in my mind. Not really well written in the scientific sense. Because sometimes you read a paper, and you're just really impressed at how exact the wording is, so that an efficiency is created. You don't have to go back and forth to see what you're talking about. I found myself going back and forth more than I really wanted to. And that was a burden, on me. And that also, I think, is a burden on people in general who get tired of going back and forth and really don't give a paper the read that it deserves, that type
Yes.
of thing.
Yeah.
So overall, it would be, where the rubber meets the road, I think, Frank, is on stage one staging. Make sure that you really have the earliest stage 1A. So you're just going to do surgery alone, and you don't take those cases where there's been an ovarian rupture or something else happening, where they should get further treatment with chemotherapy. And that's where, perhaps the impact is, but I'd be first to admit that segment of the population is reasonably rare. You're not going to pick up that many 1As stage ones in general. Mostly, 80% of your cases are going to be beyond stage one. So.
Yeah. Yeah.
But that's sort of a bias that exists in the paper. But that's all I have.
Yeah, I think the other thing, of course, is that in the end, this is all the certification is what the surgeon says is left behind. And as you probably know, Andreas Obermeyer in Australia has put together this study whereby it's called Trust, I believe, whereby the actual amount of residual disease is recorded appropriately. And I think for whatever reason it could, and we've all done it, that we may not have examined a bit of peritoneum above the diaphragm or above the liver or whatever. And so I think we do sometimes report results, surgical results, which are slightly more optimistic or slightly better than we've actually left behind. It's just, it's true of everything. And I think with self-reporting, which is what this study relies upon, very much so, um, clearly the people who do the certification don't go to each center to interview all of the various people. They say, how many cases have you done? What was the staging, etc., etc. And I think that's another weakness of the paper, that it is, there are so 193 centers. The data are going to become obscured somewhere. There's far too much going on here, I think, that, and it'll be lost in the numbers. And I think that, as you were saying, is shown in the paper. The paper goes all over the place. The discussion itself is nearly 3 pages, which is a heck of a lot to discuss when essentially the results are what we've been talking about.
Right. There's another type of example to, because this just recently happened here, and that's that when at post-surgery, when the woman was informed that there was no evidence of disease, and the conversation started about post-surgical chemotherapy, it made no sense to her to take chemotherapy, for her life to be totally changed with travel and not feeling well and all that, where she was the perfect candidate that needed post-surgical chemotherapy.
Mhm.
And essentially the message is being sent when you say there, well, no evidence of disease. A person says, well, why on the road? Well, not can't I go back to my life the way I knew it and not do anything else? And sometimes you can explain it better, but sometimes you can't.
Yes, yeah, I think that's a very good point. It's I don't know if the term is used a lot in the United States, but particularly when celebrities have had a cancer, they've got the all clear sign. Now, what oncologist actually goes to a patient and said, it's all clear? If they do that, they are wrong.
Right, exactly.
That's the end of the story. And I think that some of this comes out in this paper, and that I think the data that the hospitals, the centers have provided probably is bending the truth a little bit, bending it to fulfill the criteria that keeps them accredited, all 193 of them.
Well, sure, and one institution is willing to say on a luminary, uh, well, we left something behind. We did the best we could.
Yeah,
You're,
yeah,
you're supposed to
exactly.
do a perfect job, is really what it does.
Yeah, yeah, absolutely. Yes.
Well,
Good.
that wraps it up, Frank. It's good to see you again,
And to you.
and we'll do this again in a month.
We will indeed. Looking forward to it as usual.
Okay, take care.
Okay.